Okay. Hello, and welcome to my MASLD Community Network podcast. I'm honored to be with you today for the next installment in the virtual MASH series. I would like to personally thank GAP as well as Madrigal Pharmaceuticals and Focus Medical Communications for helping to facilitate this today. I appreciate their support of educational programs, and we hope to add more in the future. Today, we will take a deep dive into MASLD and MetALD, including an interesting case presentation. So let's get started. And I will advance. Okay, my name is Michelle Barnett. I'm a physician assistant working in hepatology in Colorado Springs. I work with Peak Gastroenterology and provide outpatient hepatology care as well as inpatient GI services. Please use this QR code to register for this meeting if you have not, but you may have already done so. As you may know, there has been nomenclature change recently regarding steatotic liver disease. Previously, fatty liver term was used, which suggested that this is seen in overweight individuals. However, this can also be seen in lean or normal weight people. Non-alcoholic was another term that was adopted, but since there are liver conditions that are not associated with alcohol, there was a stigma with this term. In 2023, a global consensus of 200 experts and advocacy groups met to address the need for a name change, which led to MASH and MASLD. We now have a more affirmative and inclusive term that reflects the underlying cardiovascular comorbidities, and this name change will reduce stigma moving forward. What better way to explain this than with a case presentation? Let's meet Ashley. Ashley is a 52-year-old woman who is referred for evaluation of abdominal sonogram, which showed mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. She feels well with no complaints. Her past medical history includes PCOS, hypertension, and hyperlipidemia. On physical exam, she has a smooth, non-tender liver edge. Her social history includes average of 2 glasses of wine per day, and her medications are listed below. All right, so review of her information. Her vitals are what you would expect. Her BMI is 29.4, putting her into the overweight category. Her AST is greater than ALT, which is consistent with somebody who drinks alcohol more, and we'll kind of delve into that a little bit more in the future. Total bili 1.2, her platelets are robust at 210. She's pre-diabetic with the hemoglobin A1C of 5.9, and triglycerides are high at 185. So one thing that's not on our chart that I would like to point out is that her FIB4 score, which is calculated using her age, her AST, ALT, and platelets, put her into the intermediate category. So her score was 2.01. And this is FIB4 is a calculation that you should use in your practices to risk stratify patients. In her case, with an intermediate category, we would then move on to fibrosis assessment, and this was done through a FibroScan. In her case, her FibroScan showed a KPA of 11.4, consistent with F3 fibrosis, and her CAP score was high at 310, consistent with severe steatosis. All right, so this is a chart that has an overview of the new nomenclature for steatotic liver disease. You will see on the left, we have the categories of MASLD and MASH. So both of these are conditions that are associated with metabolic risk factors for fatty liver disease, but neither of these are associated with in patients who have a moderate or even a routine alcohol consumption. In contrast, the square box in the middle reflects MASLD, which are those patients with metabolic risk factors, as well as increased either daily or weekly alcohol consumption. In the middle section at the top, we have weekly alcohol intake between 140 to 210 grams with the MASLD predominant case. And as they have increased alcohol ingestion, it becomes more ALD predominant with 350 to 120 grams. If somebody exceeds this, then that's actually transferring them into the alcohol-associated liver disease category. So again, it's kind of important to know what the alcohol ingestion is like, and we have to ask the right questions. So in addition to asking what my patients drink or whether they drink, I want to know what they are drinking, because there's a wide range of what is considered to be an alcoholic beverage. It can be 12 ounces of regular beer all the way to 1.5 ounces of a distilled spirit or vodka. And the alcohol content can vary from 5% all the way to 40%. So for example, wine, 5 ounces is considered to be one drink. And with our chart before, we had 14 grams as the daily intake, and that would be basically 1.5 drink equivalents, if you will. Okay. So I'm going to move forward. Okay, so let's briefly review key pathogenic mechanisms. If we've identified a patient who has high risk factors, including insulin resistance, diabetes, obesity, they have visceral fat deposition, perhaps an unhealthy diet, sedentary lifestyle, and emerging genetic susceptibility. There are some studies that are being done specifically looking at this. And then you take alcohol in addition. That combination leads to disruption in the intestinal flora with production of ethanol, triggering an inflammatory response, which accelerates fibrosis and disease progression. And this slide will actually review the dynamic spectrum of steatotic liver disease. And across the bottom, you'll see increasing amounts of alcohol use. And this does tend to coincide with increasing risks for decompensation. So the more alcohol somebody drinks, the more likely they are to have an increased risk for liver decompensation. We know that there are many drivers of this, and the more comorbidities a patient has, the more likely that this will progress at a more rapid rate. So we are now comfortable with identifying patients. We understand fatty liver disease moves from steatosis to steatohepatitis, which is inflammation in the liver causing hepatitis, not from a virus, but from the fat in the liver, and how that leads to cirrhosis. Now we need to do a better job or do a good job of quantifying exactly what the alcohol ingestion is like. This can be done through many modalities. We can use questionnaires such as the Audit-C. We can look at laboratory values such as the MCV. As we know, patients with alcohol ingestion typically have more macrocytosis. There's urine screening that can be done. And the SCRAM is actually used in some legal settings where a patient wears a bracelet that monitors and indicates the alcohol content. I've not used that, but I thought it was interesting to look at. A study by Stouffer in 2022 did look at all of these modalities for being able to be reliable predictors of measuring the alcohol content or alcohol consumption, and the study was quite supportive of using these. So we will initially do a FIB4, move on to additional studies, but then we need to look at that alcohol, just like I don't know about you, but every day when I ask a patient how their diet is, I'm given a variety of different responses. So I've been a little bit more specific on what's their protein intake, or how many fast food meals, how many energy drinks they drink a day. The same with exercise. If you ask somebody what they do for exercise, you're going to get a variety of, oh yes, I exercise every day, to I walk a lot at work, to I do HIIT training and I'm at the gym doing an hour of cardio and resistance training a day. So kind of being able to quantify this is going to be really important. And this study showed that all of these modalities are very effective. So the algorithm here helps us to assess the evidence of dysfunction, metabolic dysfunction. So BMI greater than 25 is considered obese, greater than 30. BMI of greater than 25 is overweight, greater than 30 is obese. A fasting serum glucose greater than 100. Blood pressure measurements that are high, or the use of antihypertensive drugs. Plasma triglycerides of 150, or a plasma HDL cholesterol indicate those patients at risk. And in particular, we know that those with isolated hypertension and hypertriglyceridemia are at higher risk when combined with alcohol. So once we've identified that, then we ask what the alcohol intake is like. And one way that we can do this with assurance is with a test called a PEth. This is something that will help us to quantify. And if you look onto the graph below, it says alcohol use 140 to 350 grams per week should equate to a PEth of 25 to 200. And alcohol use of greater than 350 grams per week would equate to a PEth greater than 200. Which would be more indicative of alcohol-associated liver disease. So again, we've got the identified patients, they have the cardiometabolic risk factors. We have to say, is this MASLD or is this MetALD? And the way to do that is to quantify the alcohol. So if we continue our workup on Ashley, a PEth was done and her value was 120. And so this is consistent with moderate to heavy alcohol consumption. So a PEth is a very valuable tool for identifying and quantifying alcohol consumption patterns. It can be used to monitor abstinence and detect relapse. If I have a patient with a strong alcohol history, I always tell them that I'm doing a PEth, and in some cases, it will help kind of to document that the alcohol is no longer in the picture, but may have been in the picture for a period of time. So if you look at the graph, we have blood alcohol content versus the PEth testing, and as the blood alcohol level will increase and then drop off, the PEth will continue to remain elevated. So this is the test that will tell us what the alcohol ingestion has been like over the past 2 to 3 weeks. I always tell patients it's about the equivalent of the last month. So this is a study that was presented in May of 2025 by Diaz et al., and it was done to assess patients with MASH and MASLD and evaluate the performance of non-invasive tests for detecting significant fibrosis in high-risk patients. There were 659 screened, 617 enrolled, 284 were excluded because they did not have alcohol or had missing data. So out of the 333 that remained, the analysis was performed and found that 15.7 of these patients actually had MetALD when you look at the alcohol intake as well. So if we go back to Ashley, she has PCOS, hypertension, and hyperlipidemia. Now let's kind of tease this out a little bit. This was a study, a systemic review of 32 trials involving 767 participants. And it showed that alcohol has a biphasic effect on blood pressure. Initially, it decreases blood pressure up to 12 hours after consumption, but then increases blood pressure greater than 13 hours after consumption. And if we look at alcohol and hypertriglyceridemia, mean plasma triglyceride concentrations over 10 hours after the administration of 2 standard drinks did show an increase. We would expect that. And as you have an increase in the triglyceride levels, that does increase your risk for increased fatty liver disease, because that is a direct factor. So if we look back at concluding our case with Ashley, she's a 52-year-old woman who's referred for evaluation because of abdominal ultrasound showing mild hepatomegaly and increased echogenicity with steatosis. So when you've got an ultrasound that shows increased fatty changes and an increase in size or hepatomegaly. That's something we often do see with fatty liver disease. In contrast, if someone's got more advanced liver disease, instead of enlargement of the liver, you get more of a small shriveled liver with cirrhosis. And in that state, you actually don't have the ability to hold much fat. So it's definitely her presentation with showing some mild hepatomegaly is consistent with fatty liver disease. She drinks 2 glasses of wine per day. Her elastography shows F3 and a CAP score showing S3. Laboratory studies, again with the AST. I believe in this one it needed to be switched around on this slide. So AST was greater than ALT. And again, risk factors for prediabetes with the hemoglobin A1C of 5.9 and her PEth of 120. All of this comes together to put her into the category of MASLD predominant MetALD. So if we look at the treatments, we've identified her. What are the current treatments for these conditions? So whether it's going to be MetALD, MASLD, or MASH, we start with diet and exercise. So with the diet, Mediterranean diet has been shown to have the strongest studies and support of dietary modifications. We also say portion control. We look at modifying carbohydrates and sugars. However, if you're doing a significant amount of exercise, we need carbohydrates. So we don't say to completely remove them. We often will pair them with proteins. We are typically recommending a high protein diet. Exercise is very important too. And I think we've always heard diet and exercise, but I really try to quantify that with my patients. I want Mediterranean diet. If they need to start somewhere, then perhaps 1 meal a day where they're really making the dietary changes. Maybe looking more at scrambled eggs and sausage and bacon, but not the carbohydrates, the hash browns, the pancakes, the waffles. It's amazing when people haven't really looked at this before and they don't know where to start. So trying to provide information and websites for them, have them do something with an app that might help them at least start documenting what they're eating on a regular basis, what they put into their mouth on a regular basis. If they're diabetic, they may be eligible for a dietitian consult. I encourage people to get the dietitian consult with somebody who's got experience with working with patients who have MASH and MASLD and MetALD, because you cannot get enough information to put together for each individual people. You've got people who have certain dietary patterns, people who eat more tortillas versus those who eat more rice, and looking at what they are doing currently and then how we can incorporate these healthy diet changes is important. There are apps, my Fitness Pal is one. I even have them just take 2 weeks to write down everything that they put into their mouth. And it's not to judge them, it's just for them to actually become more aware as well of what they're eating. Exercise, again, I like to say I would like a formulated program. I want 4 days a week with 45 to 60 minutes in the gym. I want a combination of cardiovascular and resistance exercises. There are studies that show that that's what leads to improvement. But if I've got somebody who's going from the couch to the kitchen, then I step back a little bit and try to figure out how I can meet them where they are. We start with references to and links to chair exercises, chair yoga, wall Pilates, things that they can do at home. People tell me they're tired when they get home and they don't have time to go out and exercise. So I kind of equate that to you've got to walk before you run. Let's get them reconditioned initially, give them some confidence that they would be able to continue to increase this, but they've got to start somewhere. Weight loss, We often will send recommendations back to primary care doctors to look at weight loss options that are available for our patients. We use a variety of comorbidities, which could include sleep apnea. We have a doctor in our community who is writing GLP-1 medications specifically for sleep apnea. So if they've got multiple comorbidities, you may have an endocrinologist and an obesity medicine specialist and primary care along with GI, and we're all doing our part to address the needs of these patients. Is this a patient that's a candidate for resmetirom? Absolutely. If somebody is drinking in excess, however, I like to kind of try to address the alcohol use prior to recommending resmetirom and letting them know that the first step would be to minimize or even discontinue alcohol, and then we could move on to what we could do to reverse the changes in the fibrosis that we found on testing. So what are my recommendations regarding alcohol use? If a patient is coming to me with recommendations on their liver, then it is my job to identify anything that could be harming the liver. If they've got elevated liver enzymes, if they've got significant steatosis or fibrosis, then yes, I would say I have reason to say and to suggest that alcohol be stopped. Now, if I don't have a reason for that, I am not their mother. I'm not the one that needs to make those recommendations. But it's amazing to me the number of patients who say no one's ever suggested that alcohol was even a factor. And these are often patients who have more advanced fibrosis. Does this patient need HCC screening? Absolutely. So we were always familiar with doing liver cancer screening or HCC screening on patients who had cirrhosis. However, we can now identify patients who have F3 fibrosis as being pre-cirrhotic and actually requiring HCC screening the same as our cirrhotic patients. So if they have F3 or F4, we are recommending, and AASLD guidance suggests, screening these patients typically with an alpha-fetoprotein and abdominal imaging every 6 months. And that's important for us to know and to adopt as we move forward. So with clinical trials that are being done with patients with MetALD, we really have to make sure that they meet proper criteria. These are based on objective biomarkers to take into consideration that there's often an underreporting of alcohol use. These objective markers need to be used to standardize the assessment of recent alcohol use and to certify alcohol abstinence in those patients who are no longer drinking. They are also used to ensure that the drivers of liver disease are present, because if you're going to be doing patients and enrolling them in trials with the definition of MetALD, then they have to have cardiometabolic risk factors, as well as persistence of hypertension and hyperlipidemia after they stop alcohol use. So we kind of have to make sure that patients that are enrolled in these trials meet the criteria. And we consider exposure to the risk factors. Typically, they have to fulfill criteria during the last 6 to 12 months. So several take-home messages today. So in addition to MASH and MASLD, there's a new term, MetALD, which alcohol intake beyond the 140 to 350 grams or 210 and 410 grams per week for women, respectively. Clinical criteria could underestimate MetALD, so the use of something like an alcohol biomarker such as PEth is recommended. And we need to ensure that the drivers of liver disease are present. We reassess metabolic dysfunction over time, which is definitely something we do. Hopefully, these patients will have dynamic factors. Maybe they're no longer having those dietary changes. Maybe they don't have that sedentary lifestyle, and we will kind of continue to assess them as we move forward. And clinical criteria for research trials should facilitate an objective MetALD diagnosis. And I think if there's anything to take away from this, we've got to identify these patients and get them referred. Start with a Fib4 if they are in the intermediate to high risk category. Refer them for further evaluation. We need to do FibroScans on these patients and then get them further assessed for all of the treatment options available, which includes diet and exercise, as well as potential for resmetirom. And if you are interested in additional disease state education, please click on this link to go to the GAP MASLD MASH Community Network. There's additional disease state information as well as the Resdifra podcast. And I would like to say thank you for joining me today. We have a few minutes remaining to address any questions you may have or clarification on any of the information presented.